discuss the importance of evaluation of ER/PR and HER2/neu and proliferation-related genes. And in the clinical practice, we really have to evaluate these very accurately, and we should do a great job. So, majority of breast carcinomas are ER/PR positive, like 60 to 70% of breast carcinomas are classified as ER positive. But when patients are ER positive, that doesn't mean that they are HER2 negative. So 15 to 20% of breast carcinomas, even though they are ER positive, they can also be HER2 positive. In addition to that, we have different molecular pathways that include PI3 kinase, PTEN, Claudins, P53, EGFR, HER3, and their expression, they are related to ER/PR, HER2/neu, but they are not completely dependent on it. Meaning that just because a tumor is ER positive or it's strongly positive, then we're not going to say that they cannot be PTEN, they cannot show PTEN loss. So each marker, we really have to evaluate independently. And triple negative breast carcinoma can also show some of the other markers. And again, by just looking at ER/PR and HER2/neu, we cannot make a guess about the expression of other biomarkers. So in the clinical practice, ASCO-CAP guidelines require that all patients with the newly diagnosed breast carcinoma should have ER/PR and HER2/neu evaluation. In looking at the biomarkers of breast carcinoma, these three markers are extremely good to predict the patients who are not going to respond to hormonal therapy or anti-HER2 therapy. Other way around saying it that these markers are excellent markers as a negative predictive marker. So if the patient has ER negative tumor, the patient is not going to receive any benefit from hormonal therapy. Similarly, if the patient has HER2 negative tumor, the patient is not going to receive any benefit from anti-HER2 treatment. However, they are not excellent markers to predict response, because if the tumor is ER positive, only 50 to 60% of the patient responds to treatment. Similarly, if the HER2 is positive, either defined as FISH positivity or immunohistochemistry positivity, only 25 to 30% of the patients respond to hormonal therapy. So they are not good positive predictors, but they are excellent negative predictors. So we really have to be extremely careful, especially on the negative end. At the positive end, we have a little more way to make some errors, but the negative, to define the tumor as negative, we have to be extremely careful because we are really making a major clinical decision. American Society of Clinical Oncology and College of American Pathologists highlighted that 15 to 20% of clinical biomarker testing of breast carcinoma are inaccurate. This has been demonstrated in Europe, this has been demonstrated in Canada, it has been demonstrated in the United States in different centers. So it really is 15 to 20% of clinical biomarker testing is not accurate. And obviously from the clinical practice point of view, this is not acceptable. Minimum quality criteria to which the pathologists have to follow for valid evaluation of biomarkers have been established by these two societies. And the beginning of 2000, ASCO and CAP convened an expert panel, including all the subspecialties, medical, surgical, radiation oncologists, and pathologists. And they conducted a systemic review of the literature and developed recommendations for optimal ERPR HER2 testing performance. Guidelines were reviewed and approved by the board of directors of both organizations, and originally it was published in 2007, and the update for ERPR was published in 2010, and update for HER2 was published in just a couple months ago. And I am going to review the predominantly ERPR component of it, and our next speaker is going to talk about the HER2 update. And the guidelines have been published in the website. It is easily available for everybody. And there are retrospective studies looking at these guidelines. And it has been shown that adherence to guidelines and use of checklists, especially reporting to ERPR, have been shown to improve the completeness of pathology reports. The panel recommended that ERPR status be determined on all invasive carcinomas and breast carcinoma recurrences. So this is very important update. The initial 2007 was saying that we have to do the evaluation on the invasive breast carcinoma at the time of diagnosis, but now it is recommended that if the patient has a recurrence, ERPR testing should be repeated. And obviously there are some recurrences that clinically it is not possible to biopsy, and it's okay to use the initial marker testing, but many medical oncologists, if it is more than 2-3 years, then they would recommend definitely to do the biopsy, even if it is only cytology preparation of the sampling of the metastatic site. We should do repeat ERPR testing on all metastases. Obviously, if the patient develops additional metastases and then additional sites, they may not require additional testing, but the newly developed metastases should be retested for ERPR. Very important aspect of ASCO-CAP guideline is not only the reporting of the testing, but also the pre-analytical factors, which include specimen handling, tissue fixation, tissue processing, assay methodology, and analysis and reporting. Tissue fixation includes multiple steps, and in the website, all these steps have been very nicely documented, and I really urge everybody, if you already have not looked at it, go into the website and look at all these different steps. Specimen should be sent to pathology as quickly as possible. Tissue, if the tissue is going to be transported without fixation, if the transportation is going to take more than 1-2 hours, definitely it should be put in fixation. If we put the intact specimen in formalin and the tissue evaluation is going to take longer time, then we should really section the tissue, because you know the formalin penetrates slowly, and especially the edges of the segmental resection, cautery is used, and this also delays the fixation. So even if it is not going to be a serial resection, even a bisecting of segmental specimen, segmental resection, is important if the tissue processing is going to take more than a couple hours. Tissue starts to deteriorate as soon as it is excised, so ischemia time should be recorded. And ischemia time is defined as the length of time from the blood supply being cut of the time the tissue is placed into fixative. So ASCO-CAP guideline now is recommending that this time should be recorded. It is mandatory for all core biopsies. It is recommended for all excision specimens. So in our center, in the past, we didn't record this for excision specimens. Now, starting last year, in addition to core biopsies, we are also recording this for our segmental resections and mastectomies. There is no question that prolonged ischemia time have a deleterious effect on both RNA and DNA and protein expression. So the ischemia time should be minimized as much as possible. Time should be recorded to help the interpretation of morphology and molecular testing. Ischemia time does not end when the intact specimen is placed in fixative, but sometimes after these big specimens are put in fixative, the slicing is also important. Proper fixation of the tissue samples is essential, and we should be using 10% neutral buffered formalin. In the United States, this still is the fixative of choice. There are some studies showing that there are universal fixatives that are good for not only histology but also RNA, DNA, and protein. Unfortunately, at this point, they are quite expensive, and it is not uniformly accepted in the United States. So we still use the 10% neutral buffered formalin. And obviously, fresh preparation of formalin is important. Formalin cross-links with DNA, and for breast samples, especially for small samples like corneal biopsies, a minimum of 6 hours is recommended. Initially, 48 hours was recommended for maximum fixation, but now it has been shown that up to 72 hours is okay for evaluation of ERPR. So right now, the current ASCO-CAP guideline suggests minimum 6 hours, maximum 72 hours fixation time. Maximum ER score occurs after 8 to 6 hours of fixation. Prior to that, there is really, especially with rapid development, rapid processing of corneal biopsies, we may have false negative results. As I indicated before, indicating negativity on these biomarkers is extremely important. So we really have to pay attention to the fixation time, and anything less than 6 hours, it is not acceptable. Especially in some centers with the major emphasis on rapid turnaround, some people try to cut the fixation time, and this really affects the ERPR result. Histology may not be affected, but it really affects biomarker evaluation. So shorter fixation times may result in suboptimal antigen preservation, and longer than 72 hours may result in protein alterations and diminished antigenicity. So 6 to 72 hours is what is recommended. If other type of fixatives other than formalin is going to be used, the results must be validated as being accurate. And this is very important because a lot of the time when a new fixative is introduced to the lab, we pay attention to histology the most importantly, but now we have to really worry about the preservation of DNA, RNA on these samples. So before we switched our fixatives, all these test results needs to be validated as accurate on this new fixative. When we are doing ERPR evaluation, it's always the main question: should we do it on corneal biopsy? Should we do it on excision? And obviously, as a pathologist, we always would like to have the larger specimens. It's always better. But if there are large, multiple core biopsies, since the fixation of core biopsies is a lot more standard and it's a lot more rapid, large core biopsy is actually more suitable for evaluation of these markers. But if it is a small core biopsy and the amount of tumor is not optimal, obviously we can always repeat it on excision. A resection sample should be sliced at 3 millimeter interval after appropriate gross inspection, and we should allow for adequate tissue penetration. If the tumor comes from a remote location, it should be bisected and put on fixation. And cold ischemia time, fixative type, and time the sample was placed in formalin must be recorded. Other important thing is that if we cut unstained sections and we store these unstained sections in the room temperature, they can be used for ERPR evaluation, but as we store our unstained slides in the room temperature, there's a decrease in antigenicity, and if the slides are stored more than 6 weeks, it is not recommended. So we can do it, but it is not recommended. If it is the only sample we have, and if we turn out that these samples are positive, it's acceptable. But if the tumor is negative for ERPR or HER2/neu, we should always question the loss of antigenicity on these samples. Specimens should be rejected and the testing should be repeated on a separate sample if the sample has prolonged cold ischemia time or fixation duration or less than 6 hours or more than 72 hours of fixation. And if the sample is negative on evaluation. If it is positive, we can accept it, but if it is negative, we should not, we should say that this is a suboptimal evaluation. Formalin fixation is also optimal, provides a good preservation for IHC and fish and other fluorescent assays. It is not ideal for RNA-based assays, but for fluorescent-based assay, it still provides a good technique. Newer processing and fixative agents require extensive validation, so we really have to be extremely careful. In terms of assay methodology, we have to use standard reagents and kits, antigen retrieval methods and automations, and most importantly, we have to pay attention to our quality control. ASCO-CAP does not require a specific technology or specific antigen retrieval. Still, the individual immunohistochemistry labs can use their homegrown methodologies and antigen retrieval system, but most importantly, the quality control steps have to be in place. Standard validated methods needs to be used, and antibodies for ERPR should have well-established specificity and sensitivity. So there are a number of antibodies that can be used for estrogen and progesterone receptor, but ASCO-CAP guideline do not specifically endorse one antibody. Any of these or any other antibodies can be used as long as they are validated and QC procedures are in place. The main goal of this ERPR evaluation is to identify the patients who are most likely to benefit from the endocrine therapy. So in addition to the level of expression of ERPR, we really have to evaluate the percentage of staining. So there needs to be a scoring system, and there are many studies in the literature looking at the inter-observer variability on these scoring systems. And one important factor is the heterogeneity in this expression of these markers. So it's very important when we are doing our scoring and inter-observer variability studies, we have to consider this heterogeneity in expression of these markers. So the actual percentage of neoplastic cells showing definite nuclear immunoreactivity must be reported because the higher the number of positive cells, the larger the expected benefit from endocrine therapies. The intensity should also be noted, and use of combined scoring systems such as H-scoring or Algret scoring system is optional right now, but by ASCO CAP. So in our center, we simply give the positivity percentage, and then we give the intensity from score 1 to 3. Threshold for cutoff points for defining ER positivity should be clinically validated against patient outcomes. Most studies now show that even if there is only 1% of the tumor cells are showing ER positivity, these patients may benefit from endocrine treatment. So in the past, 10% cutoff point was arbitrarily used. Now, ASCO CAP is recommending using 1% as a cutoff point to define ERPR positivity. So any tumor less than equal to 1% positive and less than 1% positive is called negative. It's very important that we have to pay attention to the internal control. If there is no internal control defined as normal breast parenchyma, then it should be evaluated as uninterpretable, and another sample should be evaluated. So this is very important, especially in core biopsies when we are selecting which block that we are going to use our ER testing. We should select a block which has both invasive tumor and normal breast parenchyma adjacent to it. Both average intensity and extent of staining are reported. Image analysis is an optional method. It is not required. And any interpretation method, then the people who are interpreting these methods should maintain consistency and competency documented regularly. This is a very important part of ERPR evaluation. So, excuse me. Pathologists who are evaluating the ERPR testing should have contiguous competency testing, and CAP provides competency testing slides, but you can also develop your own competency testing slides, and the pathologists who are evaluating these markers should document this competency testing. In addition to that, the lab should participate in the ERPR proficiency program, and there has to be a high concordance between central laboratory analysis and individual laboratory results. And patients who have high levels of ER benefit the highest benefit from the anti-ER hormonal treatment. So we have to document the intensity and positivity percentage. So the low positive, meaning that positives less than 5%, is one of the most difficult area, because sometimes when we have tumors like this, which is extremely weak positivity, we always show among each other, like, is this really positive or is it really background? Like, what is it? So we tend to show these low positive cases among each other before we say this is less than or more than 1% positive. And again, if there is any additional material available, repeat of ER testing is important. So in this case, for example, with the background of being very clean, even though weak positivity, we would consider this as a weak positive in less than 5% of tumor cells. So sometimes there are scattered cells which are positive, and it's again either normal breast epithelium or the stromal cells can serve as an internal control. So the positive and negative control should be included in addition to the batch control for each immunostaining. So the tissue block selected for ER/PR staining should contain adjacent breast tissue. The adjacent breast tissue provides a perfect internal control, because normal breast parenchyma shows variation of staining, both very intense staining and a very weak staining. So it's very important to try to include non-neoplastic breast tissue in the tissue block that is selected for ER/PR staining. So this variable staining is very important. If the assay only detects a few cells of normal ducts with a homogeneous staining pattern, then the risk of false negative assessment is very high. So because of that, we would repeat the staining in another block. Normal breast tissue also provides a very good, useful built-in negative control, allowing us to assess the specificity of immunostaining, because most of the stromal cells and myoepithelial cells should be negative. If everything is staining positive, then there is something wrong with the immunohistochemistry or the sensitivity and specificity of the antibody. So we really have to look at not only the epithelium but also the stromal cells. A false negative ER assay should always be our main concern. So if there is any discrepancy with histology and ER/PR results, again, this staining should be repeated, such as if we have a tubular carcinoma, it is ER/PR negative, we should definitely repeat that staining. In addition to evaluation of morphologic features of tumor, comprehensive and accurate assessment of ER/PR is essential. So in our next talk, we are going to focus on our HER2/neu evaluation. So the whole ASCO CAP guideline is really focusing on the QI issues, in addition to tissue handling and fixation, which is as important as accurate evaluation. So we always say that not only general breast cancer care, but even evaluation of biomarker is a multidisciplinary task. And it is not only the pathologist who is in charge of getting accurate evaluation of biomarker, but the surgeons need to send the specimen as quickly as possible. Oncologists should order the markers on appropriate sample. The nurses in the OR, the laboratory histology technicians, and the transportation team should really understand the importance of biomarker evaluation. Thank you very much for your attention.
Thank you very much, Dr. Sain, for these two illustrative talks.